All right, everyone. Welcome to HerniaTalk Live. This is Dr. Shireen Tofai. As you know, we are here every Tuesday. You can follow me on social media at HerniaDoc on Twitter and Instagram. And this is being simulcast on Facebook Live as well as for those of you that join us via Zoom. Today's amazing guest is probably one of the most unique surgeons we will be talking to. His name is Dr. David Santos. I have had the pleasure of knowing Dr. Santos for many, many years. He is a general surgeon, but he works at a cancer center. So he is a surgeon at the MD Anderson Cancer Center in Houston, Texas. And you can follow him on Twitter at SantosMDSurg. And we'll learn a little bit more about Dr. Santos once he says hi to us. Hi.
Hello, how are you doing?
I'm good. I'm really excited that you said yes during this pandemic, because I know Texas is a little bit
yeah, we're getting increasing numbers. Yeah, it's, but like everywhere else, I think that we're all in it together, for lack of a better word for it. It's kind of doing what it does.
This is true.
Yeah, so before we talk, I do work at MD Anderson Cancer Center, but I do have to say, for compliance reasons, all opinions expressed are my own. They're not necessarily that of MD Anderson Cancer Center. And I'm here just kind of speaking as a surgeon of 9 years of experience, and just going to tell you a little bit about my practice. So all tweets are my own. None of this is like institutional. It's just me speaking my opinion.
I love it. Well, your tweets are amazing, and the work you do is amazing. And I told you this before, I would love to have your job. It's such a unique job, because you're a general surgeon, which means you get to do everything general surgeons do. But by default, every single patient that you treat has a cancer diagnosis. Is that about right?
That's correct, yes. So in order to be treated at MD Anderson Cancer Center, my understanding is that you have to have a cancer diagnosis, or being followed for a pre-malignant condition, or being screened for some cancer prevention screening. So those are the reasons you'd be followed at MD Anderson. But 95% of my patients have some sort of established cancer diagnosis that's either in remission and treated, or having active treatment. So a lot of my patients are on chemotherapy protocols, experimental protocols. Some of these protocols don't have names, they have different kinds of alphabet soup.
And so that's very different in that you treat emergency situations that are related to cancer, but a big chunk of what you do is abdominal wall and hernia related.
That's correct. So that's something that actually developed in a much more sophisticated manner after 2017. So I started around 2014, 2015, and I was an MIS surgeon at a Southern California health maintenance organization. That's all I'm going to say. So
very well trained one, I must say.
Yes, thank you, fellowship director. So, but I really did walk out of my fellowship very comfortable with laparoscopic IPOM, and a little bit more comfortable with a laparoscopic TEP bilateral inguinal. That is actually a very hard procedure to learn. I realized, like, a year after being in it, I was like, man, this is going to take me at least 2 years to learn this well. And sure enough, it was something that you just had to kind of keep doing. I'm not actually the first person to do a laparoscopic bilateral inguinal at MD Anderson, but I was certainly it was something I did more frequently than the other person.
No kidding. Really?
Yeah, so they would kind of walk in my room and go, "What are you doing?" And I'm like, "Oh, I'm doing a bilateral TEP." And they're like, "Wow." And I'd be like, "Yeah, but you do Whipples. Like, really? Like, this is nothing compared to what you do." But it was just interesting, because their surgical oncologists, at least in that era, were more, they were more open surgeons. You know what I mean? They weren't necessarily into laparoscopy per se.
I think that's still true. That's still true. Oncologic surgeons, surgical oncologists are more adept with laparoscopy, just because surgical training before they do this fellowship has become so heavily involved in laparoscopic and robotic surgery. But as a general, I think still the majority do mostly open surgery.
I would say that's generally true. I know that for this recent class of surgeons that are kind of, these assistant level, associate level, we're all kind of in that robotic revolution right now. So some of them are doing distal pancreatectomies, they're doing like hepatectomies, Whipples, things like that robotically. So we're starting to move in that direction.
So full disclosure, Dr. Santos was one of our fellows from many years ago. I can't believe it's been that long.
9 years.
9 years, wow.
Almost a decade.
Wow. I believe I was his fellowship director at the time. And I've always kept in touch with you. I thought you were just an amazing person. I really enjoyed your positivity. And then you went and because of your training, got this really amazing job that I don't know that any other cancer center really has someone like you. Is that right?
So my understanding, now it may have changed since my recruitment in 2015, but at the time I was being recruited to MD Anderson, there was no freestanding cancer center that had just a specific general surgery department to do general surgery and acute care. I like cancer, but it's not my path. Like I didn't necessarily want to be a surgical oncologist.
Right.
And a lot of people that kind of go to these cancer centers want a pathway to be a surgical oncologist. That was never in my plans. And so I think that was one thing that was very attractive to them, is that I like being a general surgeon. I like handling what comes through the door. And so it was a mutually beneficial kind of relationship. I missed being in an academic environment where you work with people that are kind of like the best of the best in their field, and it just fit like a glove. And I have never looked back. This has been one of the best jobs I've ever had.
Yeah. So for those, most people know MD Anderson, but it's, the top, or if not the top one or two, it's among the top one or two, like there's always a debate in the United States, and therefore possibly therefore the world. Very, very advanced. The stuff you guys do from an oncologic standpoint is really neat, but that means that you as a general surgeon need to also understand not only the treatment plan, but also the complications associated with that, so that you can address that.
That's correct. So, they already did have a very strong abdominal wall reconstruction history with Dr. Butler and his group. They do primarily open repairs, and they do a lot of repairs with Stratus. That's kind of their preferred mesh that they use.
Biological
mesh. So I try to do work stay in my lane, really do a lot of laparoscopic procedures for ventral hernia repairs. But I realized right around 2015, 16, some of these things were not adequate for the type of hernias that I was seeing. So lap IPOM is really fun for me, but not so much for the patient. They hurt after that procedure, and there's complications associated with mesh. Also, some of these cancer patients have a very specific constellation of hernias. So they'll have an associated stoma with a peristomal hernia with it.
Okay, so we had Dr. Paula here last month where we talked about peristomal hernias. Can be very complicated. Mm-hmm.
Yes. So that is something that's something I realized. Additionally, like IPOM is a nice procedure for this kind of like middle of the road hernias where you can kind of put them together. But you and I both know like that can sometimes turn into a bridge procedure, and it really hurts them sometimes. So I really tried to look at different options. You want to know how I actually got into robotics? Was through the urologist. It really wasn't driven by me.
Oh, nice.
Yeah. I was pretty much like, I don't think I need to learn robotics. It's just not my thing. I can do this on my ass. I'm pretty good at it. But, some of the urologists come in and say, hey, can you repair this inguinal hernia at the same time I do this prostatectomy? And first of all, I had to make sure that was safe, and it is. And then I had to realize, wait a minute, I cannot put this mesh in robotically. I need a skill set. So that's really what kind of started me down this pathway. And because of them, and I owe them a debt of gratitude to really get me into these advanced repairs.
So for the audience, you're right, Dr. Butler at MD Anderson is very well known. He's a plastic surgeon by training. And so a lot of his philosophy is tissue-based, which is a very plastic surgery kind of way of doing things. Whereas general surgeons have been doing a lot of like mesh-based and synthetic-based. But plastic surgeons are not trained in laparoscopy or robotics. So do you feel that operating in patients with cancer, that laparoscopy or robotic surgery, and I'm going to use those interchangeably because they're just two different toys that we have that offer minimally invasive surgery. Do you feel that that's an especially useful tool in cancer patients, or not necessarily? It's very highly variable.
So it's highly variable depending on the situation. I'm finding that cancer patients have, like I said, constellations of hernias. So like colorectal will oftentimes have a midline incision and they'll have a peristomal component. Or if they have stage 3 or stage 4 disease, so they have, a liver met. That's the most common reason to do a hepatectomy, is like a colon met to the liver. They'll have this extension. So it'll go midline and then it'll go sideways, which is called a Makuchi incision. So it goes transversely across the rectus. As you can imagine, that's a uncommon incision and you can get hernias through that.
Yes.
Prostatectomies, direct inguinal hernias, that actually happens quite a bit, and so I asked them, like, what do you do with this? And they pretty much just leave them alone. So either sometimes they'll put a stitch, some of them have tried mesh, but for the most part, majority of them will just leave them alone. And they inevitably develop some sort of hernia later, which is hard to repair MIS. So that's kind of the other thing that you see. Things that I'm not necessarily comfortable with are like flank hernias and things that happen after an adrenalectomy. Those are things I don't know how to do yet. But that's where Dr. Butler's group is really good because they do those posterior column hernias really well. So I think I work well with them. Now, in terms of MIS being useful for cancer, we have a HIPEC program. So basically hot intraperitoneal chemotherapy. And they will often, and gastric as well. And sometimes they have mets to the peritoneum. They will oftentimes ask us when we're doing their hernia repair to do a diagnostic peritoneal lavage. And if they see anything kind of suspicious, they'll biopsy it at the same time. So in that respect, MIS is very useful because you can sometimes, detect cancer recurrence. I personally have not detected a recurrence, but the oncologists know what they're looking at. They're like, yeah, that's something we need to pick.
So we had, I'll share with you the screen here. We had a bunch of questions put in and they're very similar. I'll go through 3 questions. They're very similar in their question. One is, do you find that the approach to hernia repair is philosophically different in patients with cancer? What's your protocol for performing hernia surgery in an oncologic patient? And does a patient's 5-year survival affect your surgical decision-making?
I would say the short answer is,
how are you different? How can others learn about, going into a hernia operation, knowing that they've had a cancer procedure, a cancer operation, cancer diagnosis, whatever it could be? What's your thought process with that?
So technically, like the procedures that I offer are not different than what you would offer. They'd be the same technical procedure. Really, the difference is the decision-making of when you provide certain repairs and when you don't. I would say you have to have a little bit of knowledge about cancer and the cancer biology to know what would happen. So before we went online, we were talking about carcinoid, for instance. So carcinoid is one of these things, like the only treatment really is just to keep removing it. So if it's a patient in which they're going to do, say, a right hemicolectomy, but they're relatively young and they know that they're probably going to have to go back and do more extirpative surgery, this is maybe a patient I wouldn't close with a mesh. This is one I would maybe do a primary repair. If it is one that required a mesh and that didn't need a component separation, then I would probably do an underlay. I personally don't like stratus against bowel. I feel like, or biologic against bowel, I feel like it sticks. So preferentially, if I can put it retromuscular, I will. So I guess the first decision-making point is the cancer biology. Is it something that's going to keep recurring? The second decision-making point is, okay, so if it does recur, are they going to do anything about it? So are they going to do a liver resection? Are they going to go do a completion APR? The third thing is the patient preference. So, you might run into a patient that maybe doesn't have a long time to live, right? But a lot of times what we do as hernia surgeons is quality of life surgery, right? So for them, these patients might value having a hernia-free survival more than, a lifelong survival. Does that make sense? Like basically
Yeah.
they would rather have their repair and live a, higher quality of life, knowing that they're not going to necessarily survive longer than 5 years. In that case, it's like, okay, well, that makes sense. In those patients, I would offer them a repair.
Yeah, that's a really good point. So, at Cedars-Sinai, we have a wide range of patients, and I get involved in some of the more complicated ones because of that decision making. Patients who've had surgery before, if it was a cancer-related operation, you have to think, is this patient going to need another operation? And if so, I don't want them messing up my repair, basically. So that
Correct.
I'm very
Exact same.
protective of my
Yeah.
hernia surgery. So if I'm putting mesh in, which let's
Mhm.
say is a standard for like an abdominal wall incisional hernia, you have to put mesh. We discussed this a couple of hernia talks before. The recurrence is well over 50%, usually in the 60% range, and
Mhm.
that's just an unacceptable numbers. So we do recommend that you use synthetic mesh. But there are a lot of options. There's like absorbable mesh. To use mesh, there's absorbable synthetic, and there's this hybrid mesh. The problem with mesh is if you need another surgery and it's open surgery, then they have to go through your mesh. And
Mhm.
going through the mesh can either disrupt your hernia repair, or you can infect the mesh,
Correct.
or you can expose the mesh now to the contents, and maybe that could cause a complication. So I'm always thinking, okay, like the patient with carcinoid, that's a type of cancer where they need maybe 4, 5, 6 operations during their lifetime, uh, because it just comes back. You go and resect again, comes back, resect. That's like the treatment often. And so I use either a biologic or what's called a hybrid mesh. So it's part biologic, part synthetic. So it gives a
Mhm.
good repair, but the risk of exposing it and causing a mesh infection, et cetera, with the next surgery is low. Um, Actually, there's another question, but I like what you say about the 5-year survival, because the average surgeon who sees a patient that has, let's say, a 10%, 20%, 30% 5-year survival, but otherwise looks good. So let's say that
Mhm.
they're eating, and so they don't look sick, but we know that the tumor is like a late stage tumor, and they had their surgery. The average surgeon would probably not operate because they feel,
Mhm.
right? They don't feel
Yeah.
comfortable. They feel that it's high risk, but the surgery itself necessarily isn't high risk. You're just adding an operation during the patient's survival, which may improve their quality of life.
And oftentimes that's kind of what they want. They want improvement in their quality of life. And that's a lot of my discussion in the office. Is like, it's interesting when you work at a tertiary level cancer center, because a lot of them have accepted their mortality. They know that they may not have long
Mm-hmm.
on the earth. So their discussion is sometimes different. It's not necessarily a depressing, sad discussion. They know what they want. They're very focused on trying to live their life. And so it's your job as the physician to kind of facilitate that. If, the surgery that you're going to offer them is relatively low risk, right? So I'll give you an example. So sometimes these patients with cirrhosis, you know what I mean? You
Yes.
like, you got to make sure that's the one that's kind of my hard stop usually is cirrhosis. So like if they have
Yes.
cirrhosis that's from a portal vein thrombosis, that really has to be repaired before I move forward. But if they can get it to a level where the ascites is minimal and I can stay outside of the abdomen, I may offer them an onlay, knowing that it'll temporize them for a couple of months. And if that couple of months is what they have left on the earth, then
Yeah.
I have contributed some sort of quality of life to them, even though I would have not necessarily done that operation otherwise. So it's really, you have to have a lot of, I think, arrows in your quiver when you have cancer patients. So you have to have different types of techniques for different patients and accept
Yeah.
different levels of risk. So I think that's kind of like a lot of what I do with the consultations with these cancer patients.
That's a good point. Different levels of risk. It's all relative. So what I tell my residents is, life before hernia. So if a patient's life is at stake and they have a hernia, focus on the life-saving portion of the operation. The hernia can come later.
Mm-hmm.
But at the same time, if you're improving quality of life and you're not increased, and they're able to survive the operation, enjoy that quality of life, then maybe it's not the perfect hernia repair, right? Maybe it's
Correct.
not like the one that you would do in a young, healthy athlete, but it would be something that would improve the quality of life. I think people need to understand, those people that watch this hernia talk, is that we have a lot of tools in our toolbox, right? Open,
Mm-hmm.
laparoscopic, robotic, and then within that, with mesh, without mesh, different types of component separations and tissue repairs. We have wide range of mesh products. What do you use for mesh in what are your different options that you have available?
So since I prefer robotic intramuscular, it's always going to be some mid-weight polypropylene mesh. To me, that's really what it
Yeah,
is. Um,
standard, flat,
I'm sorry.
normal. Yeah, just
Yes,
standard,
flat.
flat, normal. Yeah.
Yeah, pretty much. Um, is the mesh infection rate higher? It can be, but you know what? To be honest with you, even though like I've had some infections where you have, synthetic mesh. I've been able to salvage them with antibiotics. I haven't necessarily had to go back and remove the mesh a lot of the times. Um, in terms of, oh, here's a special thing about cancer patients. Sometimes they're neutropenic. All right. So there
Which means
isn't
their
a
white
lot.
blood cell count is very low,
Yeah,
and
less
that
than
means
zero
that
point 0.2.
they're when that less than 0.2 is the definition.
Less than one is
Less
the
than one,
definition. Yeah. So
which means
go ahead.
that only makes them higher risk for infection. Does it also affect their healing?
Definitely affects their healing. So earlier
Definitely.
in my, my tenure there, I was using, like sometimes the hematologist will say, I really need this lymph node biopsy. So I need you to take it out of their armpit. And I'm like, their white count is near zero. I don't feel like this is going to be a good idea. And sure enough, like when you just do even that little tiny incision, sometimes it doesn't heal. And when I would look at that, I'd be like, man, if I do this in a hernia, this may not heal depending on their white count. There are
Mm-hmm.
some things that I learned that you can do to raise their white count. So I learned a little bit about some of these agents that you use to elevate white blood cell count, such as Neupogen and
Yes.
colony stimulating factors and so forth. With that,
So
you kind
you
of have to
use that in your hernia patients?
sometimes, depending on whether or not
Wow.
they're in their
Okay.
nadir. That's the other thing. You have to kind of catch them in the middle of their cycles. So oftentimes they're having lots of rounds of chemotherapy, but their white blood cell count will rebound. So you kind of have to catch them like right when they're so they may look really bad when you see them in person, but then by the time surgery rolls around, their white cell count may have rebounded, or their oncologist might be able to raise their white blood cell count to promote healing. So
Yeah.
that's another trick that I've learned. It's like you have to really be multidisciplinary with cancer patients. Like
Right.
they're your patient, but they're also the oncologist patient. So you really have to share ownership. And I found that relationship to be beneficial, because we talked a little bit about survival. A lot of things that patients that I thought would not have good survival are actually having great survival, because we've had some advances in chemotherapy, in particular immunotherapy. So
Yeah.
these nibs and mabs, as I call them, didn't exist when I was a medical student. Like it was not something that existed, but these targeted drugs that work, for instance, on melanoma, with very little side effect to the patient and a lot of cure. There's a lot of things that you didn't think would necessarily be curable are now starting to be kind of curable. And so because you don't necessarily have that fund of knowledge as a surgeon, it's really valuable to talk to your oncologist to figure out these side effects. And so that's the other thing I would encourage. If you see a patient on a trial, you probably want to talk to their oncologist about the side effects and how you can work to get their white blood cell count optimized.
Yeah. Communication is key when you're in this multidisciplinary treatment of the patient. We have a question about mesh removal. What's the thought of mesh removal? What thoughts go in your mind when treating patients that have cancer and may need a mesh removal?
So my philosophy is this: try not to get in that situation where you have to have mesh removal. That's kind of my thought. Prevention is
I
probably
know, right?
better. Prevention is
Yeah.
probably better than getting in that situation. So if they have a smallish size hernia, so less than 2, obviously you don't put a mesh. Um, if they have a colostomy takedown, for instance, at the same time that they have a, ventral hernia where they need some sort of repair, that's a patient I would probably put a biologic mesh in. If they have no further surgical options, like the oncologist will not offer them any other procedures, but they have this wide hernia, I'll put a synthetic and it might do a robotic. But I
Yeah.
try not to get in that situation at all.
Here's another question for you. Is there an issue with placing mesh in patients with cancer? So can it affect their cancer itself, or can it affect their treatment options? What do you know about that?
Meaning like with the implants onto the mesh, is that maybe what this question is referring to?
Yeah.
I would say, to be honest with you, like I have not noted an association between mesh placement and cancer. But I do think there are appropriate places not to use mesh. So if you have a patient that has a peritoneal type disease or something that has potential to move to the peritoneum, maybe not the best idea to put a mesh in that patient. It might be better to use some sort of onlay technique. And that would be kind of what I would do.
You know, there are some people that claim that mesh can cause cancer. Have you ever heard of that?
No, I have not heard of that, but I would imagine that there are some people that believe that.
You know, the reason why they believe that is I believe there was one paper that a patient had a mesh complication. It involved an enterocutaneous fistula, and by definition, a mesh infection. And I think they had like a skin cancer in the area of the inflammatory process. And so, I mean, that doesn't mean the mesh causes cancer. If you had the fistula, regardless of whether there was mesh there or not, that may have been a risk. As we see, there's like, same happens when you get a skin burn, right? When you get a burn, that burned skin is at risk for cancer in the future.
Correct.
There's a term for that. Something's ulcer. Is that a marginal ulcer? Is that a marginal ulcer?
Yeah, it's a marginal ulcer.
Yeah.
Yeah, burn, right? Oh man, that take me back to
That
2007.
took me
Jesus,
back.
like I don't remember that. God, but no, yes.
Yeah. It's been a while since I've treated a burn patient.
Yeah. No, but I think people will see associations, but they won't necessarily identify causation, and they kind of mix up the two. Yeah, there might be an association, but it doesn't mean that was the causative factor for that.
That's
in my
correct.
9 years as a surgeon, I can say with confidence, I do not know of any association between mesh causing cancer.
And you work in a cancer center.
Yes. I mean, now I could be wrong, but I have not seen that. No.
I mean, I always say we don't know everything, but that one for now, at least, we've been using mesh for longer than I've been alive. So, yeah, you would see a lot more issues if that were the problem. But let's go back to that question, because I think it's a useful question, which is that putting mesh in, does that maybe delay their need for chemo, or can you irradiate the area after mesh is placed? Like, what do you know about that?
So I used to think irradiated tissue would be difficult to operate in. I think it causes more scarring per se, but placing mesh, I think if I knew that it was a high risk area for healing because it would have poor vascularization and so forth, and there was a higher risk for infection, that's a patient I would probably consider putting a biologic mesh in. Let me see, in terms of, what was the other thing about that? Like you said,
like is it possible to irradiate the area after mesh was placed?
If it was somebody that I knew that was going to get multiple rounds of radiation, I would probably put a mesh that would be less risk, in terms of infection. So it'd probably be a biologic. But again, like if I had no options, for instance, I did a peristomal hernia, and I had to do a preperitoneal peristomal hernia repair.
Yeah.
I never thought I'd have to bust that out, but I totally did because it was the only option that I had for this patient. I've never put a biologic in that situation. So I was really only the only choice I had was a mid-weight polypropylene synthetic mesh, because it's not described with biologic. He hasn't described it with biologic. I wasn't about to do that to a patient. And I accepted a little bit of risk, meaning mesh infection and so forth. But again, it goes back to that whole idea, like none of these patients are going to be perfect. There's always going to be some sort of issue, and you're going to have to know how to manage and manage complications well and make sure that they are handled in an appropriate fashion. That's pretty much it.
Right. The next question is, you kind of talked about it, but maybe you can be more specific. How does chemotherapy and or radiation affect healing for hernias after hernia surgery?
So immunosuppressive chemotherapies, things like cyclosporin, things that decrease your absolute neutrophil count are things you have to watch out for. Also, VEGF inhibitors like bevacizumab. So that's Avastin. That's a common drug used in things like colorectal cancer and other cancers as well. 5-FU, kind of the same thing. They work by impeding healing. But as I said, some of these so if you have a patient that's on that, you want to time it when their nadir has passed and they're ready to have surgery because their absolute neutrophil count increases. If it doesn't increase to about 1, and that's just an institutional thing we use, 1, it really doesn't have a lot of high level data, but for us, an absolute neutrophil count less than 1 is kind of an indication that we should give them some sort of white blood cell count booster. So if we can get it above 1, then you can operate on this patient probably. In terms of patients that have immunotherapies, really the side effect for immunotherapies changes depending on how that antibody was derived. So if it was derived from a human, so it's a Zumab, usually the manifestation in these patients is going to be systemic. So any kind of problem is going to be skin rash, pulmonary, things like that. And it doesn't really necessarily affect wound healing so much. Any kind of MAB, where it's just like from a rat, for instance, then that usually does not affect wound healing as much. It's more, again, they're systemic things, but you have to look specifically at some of the side effects. The main culprit that a lot of people point to is bevacizumab, because it's a VEGF inhibitor, which impedes wound healing. Radiation itself, I haven't really found to be too much of a problem, other than sometimes it's just very scarred and you can't define the planes very well. So in that case, you kind of have to figure out, all right, I can't really do a retrorectus to figure out the planes. I might just have to do an underlay. And that's how I handle radiation.
And is there a certain amount of time after chemotherapy that you wait before, let's say they're done with their chemo, and during that process a hernia developed, how much time do you wait until their last cycle before you schedule them for surgery, minimum?
So, the wisdom of older surgeons, it seems, and, just from reviewing charts and working in my department, they seem to wait about 4 to 6 weeks, but that seems arbitrary. There doesn't seem to be a specific reason for that. Maybe practice-based learning, because maybe that's what they have learned throughout their practice. But in terms of a high level, this is when you should do it. I think there's equipoise to that, because you have to figure out whether or not delaying their chemotherapy is worth it. Sometimes they can't wait too long. And so you do have to accept, hey, I may have some impaired wound healing because this person can't wait. So if their oncologist is saying I got to do it at 2 weeks post-op, then that might be the time. My feeling is this: chemotherapy tends to give patients a functional status decline, and that's very important for us as surgeons. So if they can't walk or they're wiped out, that's really going to hurt their postoperative recovery, because we want them to walk. We want them to not get some of these postoperative complications. And so
that's a really good point.
Yeah, so if you need to operate on these patients, you kind of have to time it in between when they're going to be strong enough to recover. So one thing I do is if they can't even get up on the table, then probably not a good idea to operate on this. If they're in the office and I ask if they're in a wheelchair and they can't climb up onto the examining room table, that's probably a good sign that they won't get up after surgery. Additionally, they oftentimes arrive in my clinic in wheelchairs, so you have to be very honest with them, because our place is big, so they put them in wheelchairs to get them from place to place. So functional status is very important, a very important discussion I have to have with them. Something I kind of ran across recently that never really occurred to me, but chemotherapy can cause something called chemo brain. That is a very real thing. And so I noticed when I would talk to some patients, they would be very foggy. They wouldn't, I mean, they looked normal, but they would be talking and it's almost as if you would repeat something like 8 times and they wouldn't really get it. And I'm like, why are you, I mean, are you just old? I mean, like what's going on? Sometimes chemotherapy can affect the way that, affect that patient's mentate. And so
Yeah.
when I can't figure out why they're not comprehending what I'm saying, I oftentimes ask them like, so what's your experience with chemotherapy been? Have you had problems orienting? Have you, things like that. And so that is something that's unique to these patients on chemotherapy that I think a lot of surgeons take into account, that mentation may not necessarily be 100%. So that's the other thing I want to say about that.
That's a good point. So you're okay operating, let's say the chemotherapy is done, and then 4 to 6 weeks later, assuming they're otherwise okay to have surgery. What about in between cycles? If it's something a bit more urgent, what do you do with that? You just work with the oncologist to see if they can maybe delay the next cycle and how serious that would be?
Yes, absolutely, because they're the ones that really know the mortality rates on that. They run their trials, so they're on sometimes very strict trials. So if they have to wait a certain amount of time, then you have to, like they have to take them off the protocol, and that delays their therapy. So you have to make sure that it's not going to interfere with their cancer treatment, because that's why they're there at a tertiary center. They're there for that chemotherapy protocol, but they can't help it. Sometimes they get diverticulitis, sometimes they get an incarcerated hernia. But the main thing that I have found, at least, is that you can't predict, a certain time period, but you can say, hey, this is what I need to do, the oncologist, and you then negotiate, and then you accept a certain level of risk depending on the complication that could occur.
Right, right. On that note, there's another question that's relevant, which is, what are your tricks for either predicting or handling ascites when doing a hernia repair or lymphatic leak? So let's say it's, I don't know, a patient that needs a hepatobiliary surgery or some type of pancreatic surgery, and last time they had surgery, they had ascites, or they currently have ascites. Ascites is fluid collecting inside the abdomen. It can cause not only pressure, but like any fluid, it can leak into the crevices of hernia repairs and so on, and wounds. What do you have tricks for that?
So a lot of times you have to screen ahead of time and think to screen ahead of time with imaging to see how much ascites actually have. And you look in time, like how close it is to the repair that you're having. So even if they have kind of like a little ascites and the scan is old, I tend to get a image that's a little bit closer to the time that they want surgery to make sure that they don't have massive ascites, because it can hide. Also, you want to treat the underlying condition. So sometimes they're going to have some sort of portal vein thrombosis. So say they got splenectomy and distal pancreatectomy. Splenectomy is one of the culprits that can cause portal vein thrombosis. And so the treatment for that is to get rid of that clot. Reading the operative note is very important. So any kind of surgery that kind of messes with the portal vein, so like a Whipple, a distal pancreatectomy, splenectomy, some sort of a Coker, some sort of, what's that maneuver where they put it around the hilum of the liver? I forget the official name, but they put a tourniquet around. Pringle, yeah. Sometimes a Pringle maneuver, anything that messes with the portal vein, you kind of have to think in the back of your head, could this person have, that's embarrassing. You kind of have to think about whether or not the person has some sort of portal vein thrombosis. And so then you go down your pathway. You're like, all right, do they need an ultrasound? Do they need a CT? And if you diagnose this, which sometimes you can because your specialists are not thinking necessarily like that, they can be treated with anticoagulants for a time, have their ascites resolve, and then go and do the surgery. Now, in terms of lymphatic leak, I haven't encountered that too much. I think I see that more when I do mesenteric lymph node biopsies, because you're working with chyme and you're working with the mesentery. But I don't have a good way to predict lymphatic leak. I think the best thing is just to understand the patient's history, understand what they might be at risk for, depending on the type of surgery that they have, and make sure you diagnose it early before you operate on them.
Yeah, it's just so fascinating how much you've learned how much you're able to share with us as well. I'm learning a lot. There was a patient that I was asked to be involved with, and that was actually my question for you, which was about the ascites, because the original procedure did cause a lot of ascites, and that meant that the second surgery may have the same kind of issue. And then, I don't like to put, so my philosophy is, in general, I don't like to put mesh inside the abdomen. I like to do it either, like, basically away from the organs, in the bowel,
Mm-hmm.
for multiple reasons. And also with cancer, I just don't like to do that. And then the ascites issue, there's a risk of mesh infection, there's a risk of wound breakdown, which will expose your repair. You want to make that hernia repair so that it doesn't break down from the leakage. Also adds a lot of extra abdominal pressure. So it's like taking your hernia repair and then trying to stretch it out. So all of those are factors that I take into account when I do these operations. And I feel that maybe the average general surgeon who does hernias in addition to 1,000 other different operations maybe doesn't necessarily take that into account, and then you fall into a problem.
Mm-hmm.
Do you think that patients that have a serious cancer diagnosis and then need a hernia repair, do you think they should be seen by someone like you as opposed to their local general? Like, should they shop for a hernia specialist, or is that just overkill?
I don't think that's overkill at all
Yeah.
because, you know, as a general surgeon, a lot of the reason we become surgeons is because we're attracted to an endpoint. We see a problem, we want to fix it. It's a nice, neat little package, and we have a plan for it.
Mm-hmm.
But
Yeah.
when it becomes complicated like this and becomes multidisciplinary, I've seen a lot of my peers go, I don't want to touch that. You know what I mean? But I'm kind of unique in this respect because I kind of
I
like the
want to
mental.
touch that, actually.
Yeah.
Right?
I like the mental journey because, like, you know,
Yes.
part of the reason I became a doctor is because I do have a little intellectual curiosity. So
Yes.
I think that's why I'm kind of perfect for this job, because you really got to think like 2 or 3 steps ahead. A lot of the times, a lot of what I do is prevention. It's not so much, you know, it's not so much just fix this hole in the bucket, so to say. It's like, look, there's this bucket, there's a hole in it. You have 5 different ways to fix it. What's going to best work for this person, you know? And so you have to kind of dig into history, etc. So in terms of ascites, I do encounter ascites, but it's usually in the setting of an emergency surgery. So it's usually somebody who has ascites with incarcerated bowel. You know, we've all been
Yes.
there. And my colleagues are sometimes like, you know what, Santos is the best one on, on the team to handle this, which is not necessarily I don't want to say it's a dump, but but you know, I do have some expertise on this. And this is how I handle that patient with ascites. So that's an open surgery. That's not minimally invasive. That's not nothing. It's open because you're going to have to evacuate ascites. So when you evacuate the ascites, yes, you repair the hernia. Most of the time, that's going to be an underlay for me because it's oftentimes not something you can close primarily. And you do need some sort of mesh buttress because I think it's going to recur if you just sew it. So you need to, you know, put some sort of buttress. But here's the kicker. You have to realize your liver physiology after this is done, because this patient is not done after you do this procedure. They get thirsty, they get hepatorenal syndrome. And so if you are not on top of your medicine, you can't just go, oh, just let medicine handle that. They're not as aggressive as you. So like you have to make sure that you understand this liver physiology that's happening after you handle this patient with ascites. And sometimes they have ascites because they have lymphoma. So then at the same time, you're dealing with, you know, like their chemotherapy protocol and whether or not you got to give them Neupogen. So it's a little medicine-y, but medicine-y with some aggressive tactics, so to speak.
Yeah, I think what's cool about surgeons is that we are, I mean, we don't know as much as internal medicine doctors in the nitty gritty maybe necessarily, but we know a lot of internal medicine because we need to integrate that into the care of our patients before and after surgery, in addition to the surgery that we do. I think that's fascinating. It's one of the reasons why I love what I do, is because, and I feel like you do the same, is that I work with a lot of specialists. I work with the internal medicine doctors. You know, one patient has factor V Leiden mutation. One patient has this other like medical diagnosis that I need to read up on and learn. And at the same time, I work with a lot of different surgical specialists, urologists, orthopedic
Mhm.
doctors. So in residency, I didn't get to see necessarily what they did, but now that I'm working with them and collaborating, it's really fun. I like learn
Mhm.
new things. Yeah,
Like
I like
these
it.
ileal conduits, that's a good example. So ileal
Oh,
conduits is a good
that's a
example for
hard
me.
one.
Yeah, I see a lot of those. And so I've had to actually play in other surgeons' backyards, so to speak. I have to learn
Yes.
procedures a little bit. So I noticed I started getting a few more ileal conduits because they get these peristomal hernias. But when you
And
get in
they're
there,
very difficult to repair because it's a large, there's multiple ways of making an ileal conduit. So these are people who don't have a bladder, let's say
mhm,
for bladder cancer, right?
yes,
And so the urologists very interestingly make a bladder, which is basically a bag
mhm,
to store your urine, and they make it from the small intestine,
correct.
usually.
So they take these ureters, which are from the kidney, and they anastomose them to this new bladder, right? But when you get in there, it all looks like chicken. I mean, it really
Yeah.
just looks like meat. You don't know what you're looking at. And so I had to kind of, learn different techniques. So I had to, number one, watch the video and realize that they pass this ureter underneath the sigmoid. So that's
Yes.
one thing. And then use your bag of tricks, like dig into your backpack, find the arrow and go, hey, what can I use to identify this ureter? I guess I can use ICG, right? So these are things that you have at your disposal, and I probably can do it robotic because it's easier to place this mesh in a much more fitted fashion than if I were to do it laparoscopic, at least to me. But these are, and then again, it comes with that constellation. There's that ventral hernia that's associated with this peristomal at the same time. And so you kind of have to fit your mesh to that. It's a very complicated kind of thing, but I've had to kind of go back and look at how other surgeons operate to tailor how I do my operation.
Yeah, so ileal condoms are unique. So like any stoma, they have to go through the abdominal wall. It's usually not as big of a hole as a peristomal hernia, which involves usually small intestine or a colon. Um, but it can be big depending on where they made their their new bladder from. There are different techniques, and there's one name I forgot. The name is kind of a cool name. Starts with a B, I think. That's the one that gives you the most hernias. But okay, the one thing I learned, which I'll share with you, is ileal conduits, because it's small bowel, are very, very sensitive to mesh. So I've had multiple patients that have had a typical peristomal hernia repair where the mesh touches the ileal conduit and it's eroded into the conduit. So I do not do any intraperitoneal mesh. I stay away from the conduit, stay away from the ureters because you don't want to mess up that reconstruction.
Mm-hmm.
And I do those as either on like open onlay or open retromuscular, and I stay away from the conduit as much as
Interesting.
possible.
I know that I don't like biologic around that area because biologic does not last. And then also keyhole.
Correct.
Keyhole does not work. I mean, like I've done a number of, just to kind of get out of a jam, right, to do a keyhole.
Yes.
But they tend not to work either. Um, it is a
The
developing
good thing with
field.
conduit is you can't obstruct the urine.
True.
It's hard to obstruct that. You can make it too tight and it's still okay. Unlike
Yeah,
a
that's
regular stoma where you'll get a bowel obstruction.
so that's actually something I learned from you, and I still use in my clinic. This is a Goldilocks operation. You cannot make it too tight, you cannot make it too loose, and I'm very anal when I do this surgery because it has to be just right. So I deflate the abdomen, I blow it up, I make sure that urine is flowing throughout the case. It's a nerve-wracking surgery to do.
Yeah, and like you said, you have to be really cognizant of where those ureters are. That's one operation you don't want to mess up for the patient. All right, I think there's one more question. Okay, how have you changed your surgical technique since working at MD Anderson?
I haven't really changed it all that much. It's more of the surgical approach. I was talking about this with my physician assistant in clinic today. It's more about when you do the appropriate surgery. That's really what's changed.
Mm,
I will say that the most important change that has happened since working at MD Anderson is the acquisition of robotic surgery. So
Yeah.
I kind of hate to say it, but I feel like TAR is kind of a magic bullet. I feel like you can use it for almost everything, but it
Yeah.
is one of the hardest procedures to learn. I spent all of 2017 learning to do that robotic and open at the same time because I didn't get a lot of ab wall when I was a resident. So I kind of had to learn a lot of that. And so I guess my surgical technique has changed in this respect. I do a lot more intramuscular mesh than I used to. I do a lot more component separation, in particular the posterior component separation. And then I had to pick up advanced robotic techniques, such as the robotic ETAP roof stopa that Igor Belyansky does. That actually was a game changer for me because not everybody needs a TAR, right? That's a very big operation for sometimes these moderately sized hernias. And the only alternative I had around 2018 was just to split them open from xiphoid to pubis. But since I acquired that skill set, that is now my second most popular robotic repair. So I do that a lot more than I did 2 years ago. So I guess the answer to this question is my technique has changed more toward MIS, intramuscular with component separation. I recently looked at my own outcomes because I was curious, all right, I have enough now. I kind of want to know how I stacked up to other people. So my length of stay, because I'm a relatively conservative surgeon, I don't like sending people home unless they're like passing gas, and I'm old school like that. They have to pass gas, right? And be able to eat. So my length of stay for these operations is about 3 days. In terms of their length of stay when we were doing it open, like it would be 5 to 7. So that's a significant difference, and also statistically significant. Additionally, I don't fixate it anymore. I just glue the mesh in, and that has worked really well. So I haven't had a lot of surgical.
Spray the glue?
Yes.
So drip it, spray it?
I spray it, and I use about 20 cc's. So like I use 20 on the top, 20 on the bottom, and I'll place a drain. So because I've eliminated fixation and transfascial kind of closure, that has changed their pain regimens. And so like I'm sending them home now on maybe 15 pills of tramadol, and they maybe use 5 of those. Yeah, so that actually helps with their bowel function and their recovery. So again, changing the technique, changes the pain, changes their length of stay, really has kind of revolutionized how I do things now as opposed to maybe 6 or 7 years ago.
Yeah, that's true. Tell us how you're doing in Texas. We have 5 minutes. I'd just like to get a little update of Texas. You mentioned that you're currently banned from, not you personally, but your city is banning, is it citywide or statewide elective surgery?
So statewide, yeah. So Governor Abbott has a state mandate where we don't do elective surgery. It's only surgery that is emergent because they have a risk of contracting COVID, or has a has minimal risk of taking a lot of resources in the hospital for COVID patients. So, an outpatient surgery, but things that I'm allowed to do right now. So vascular access for chemotherapy, hernias that have potential for incarceration, or something that's going to prevent them from getting their chemotherapeutic regimens because they have not, like it's going to delay their therapy. So those are things that I can do.
Wow. And you're staying safe?
Of course. Always.
Yeah, I miss you. I feel like we haven't had a lot of meetings to go to the past year. They all got switched to being online. Are you part of the American Hernia Society conference this year?
I recently got accepted. There's a video, a little plug there, that was going to be presented in New York. So it's actually interesting. So it's a robotic tap video. There's tons of those, but this is from the perspective of someone who works at Cancer Center. So just a little spoiler, there's a spigalian that happened after a tummy tuck. There is a defect in the abdominal wall that happened after a tram. And there's a suprapubic that is on a bony provenance from a suprapubic catheter. So like these are weird hernias that I was able to solve with a tap, essentially.
That's awesome. Yeah, we didn't discuss the breast reconstruction surgery, but tram flaps, deep flaps, these are all different abdominal wall procedures that are done as part of the reconstruction of a breast, often for cancer. And that can cause some serious abdominal wall defects they can be really tricky because you're missing, well, in a tram flap, you're missing the actual muscle and one layer of fascia. And with a deep flap, you can be injuring that fascia as part of the deep flap. So yeah, those can be tricky to repair.
And they may or may not have a underlying biologic mesh, so like it's a again, read about your patient, learn to read CTs, like really be diligent about how you take care of these patients.
Yes, totally agree. Totally agree. Well, I hope you stay safe. We were banned in Beverly Hills only, not Los Angeles City, Beverly Hills only, from elective surgery for about a month, I think. Mostly because I'm surrounded by plastic surgeons in Beverly Hills, and they didn't want people coming in getting like breast implants and Botox facelifts during a pandemic.
Interesting.
But the practice in Beverly Hills, I was caught in that, which was fine.
Right.
Safety first. But yeah, to have the whole state shut down for elective surgery, that's a big deal.
It is.
That's
So
a lot of surgeries.
yes.
And a lot of hernia surgeries.
I'll be honest though, like I feel safe working where I work because I feel like they really do take care of us. I haven't felt unsafe in my work environment. I can't say that for everybody, but I feel really blessed to be where I am at.
Good for you. Good for you. I wish you were in California because then we could hang out some more.
I don't
But
want to get
I
that thing
did.
in my nose, I'm kind of not out with that. I'm like, I don't know if I want that.
I know. So we had a meeting in Houston, and Dr. Santos was awesome, and he showed me his workplace, his office workplace at MD Anderson, which is a fascinating, like, huge village, basically, filled with buildings, and I got to check out his office, but also the different kind of patient areas and the operating room areas. So, as surgeons, that's like the sightseeing we do. We go to different hospitals to see how other hospitals are. And it was a wonderful place. And I'm so proud of everything you've done since your fellowship. You've been great. And I like that you keep in touch. And thank you for sharing your time with us.
Very good. Well, thank you for having me. I totally appreciate it.
Thank you. So on that note, I would like to just say thank you to Dr. Santos for his time, and for all of you who have been joining us. You know that we will have this broadcast on YouTube for you to share and rewatch and share with your friends. It is already on Facebook Live, and I will post the links of that on Twitter and Instagram. Thank you again, Dr. Santos. And next Tuesday, we will have yet another amazing surgeon to talk with. And on that note, everyone have a great rest of your evening. And I hope you all stay safe. And thank you again. Bye, David.
Bye.
Bye-bye.